Hello, everyone. I'm Dr. Salama Al-Bugaish. Welcome to the 61st edition of MENASO, Education Academy Cerebrovascular Grand Round, and the first webinar for this year on women and stroke, understanding risk, closing gaps, and advancing care. This session will spotlight key developments shaping the future of stroke management. Our webinar series successfully brought together a global community of over 5,000 participants last year, a testament to the strength and relevance of our educational initiatives. This success is driven by our esteemed faculty of 45 speakers, encompassing both distinguished local experts and internationally renowned professors and consultants. We are honored to host this exceptional lineup of speakers who will lead a program featuring cutting-edge research, expert perspectives, and engaging discussions. Together, we aim to elevate standards of care, strengthen clinical practice, and ultimately improve outcomes for patients across the region and beyond. I would like to now welcome my co-moderator for the session, Dr. Helana Hatoum.
Thank you, Dr. Salama. Can you hear me?
Yes.
Okay, thank you, Dr. Salama. My name is Helana Hatoum. Good evening, good morning for everyone. Today, we will be exploring women and stroke management. This is a very important topic with yet a lot of unanswered questions. This important topic is through a whole life span for the woman, and in particularly maternal, when we talk about maternal stroke affecting mother and the fetus. Current guidelines, unfortunately, offer limited guidance in this regard for managing stroke, mainly in pregnant, peripartum, postpartum, and lactating, because these cases were excluded from major trial. Our current best clinical approach is based on case series, observational studies, and expert opinion. And this is exactly what we are going to do today by listening to two experts in this topic, Dr. Nuran Taher, presenting Stroke in Young, hormones, pregnancy, and the gender gap in risk, as well as Dr. Aisha Brahim Al-Bakr, who will talk about sex-specific disparities in stroke care from presentation to long-term recovery. These topics are very important, and I'm sure you will find them both insightful and informative. The questions and the answer session will be after the last lecture. Now it's my pleasure to introduce our first speaker, Dr. Nuran Taher, who will present Stroke in Young Women, Hormones, Pregnancy, and the Gender Gap in Risk. Dr. Nuran Taher is a well-known stroke neurology consultant at the National Guard, Riyadh, and Stroke Fellowship Director at King Abdulaziz Medical City, Riyadh, Kingdom of Saudi Arabia. She served as a member of the MOH Stroke Committee in the Western region. She's a Director of Virtual Care at the Ministry of National Guard Health Affairs. She's a stroke project leader at King Abdulaziz Medical City, a neurology program deputy at King Abdulaziz Medical City. Dr. Nuran completed her bachelor degree from the College of Medicine at Taiba University Al Madina in 2009 and subsequently completed her residency training in adult neurology and King Abdulaziz Medical City National Guard Health Affairs. Without further ado, Dr. Nuran, welcome. The floor is yours.
Assalamu alaikum. Good evening and good morning. Thank you, Dr. Helana, for the nice introduction. And also, I would like to welcome Dr. Salama, that she joined the stroke committee recently. طيب, what a day actually to talk about stroke in young women. I just came 2 hours ago from the hospital. My sister delivered a baby boy, and I stayed with her for 7 hours during the delivery. So it was quite complex delivery. Alhamdulillah, things went well. So today I will be talking about the hormones, pregnancy, and gender gap in risk. So what is different in women compared to men in regarding stroke? I have no conflict of interest related to this presentation. And actually, when we look to the guidelines, as mentioned by Dr. Hilana, actually, women, they are underrepresented in cardiovascular disease researches. And most of these guidelines, only 1/3 is actually women. So we are talking about 2/3 that are actually men. And stroke remains the second leading cause of death worldwide, but in women, it's the third leading cause of death in women. Not only that, if you looked at stroke and breast cancer, actually they are the same. So stroke kills twice as many women as breast cancer. But when you look at all the campaigns, everyone is talking about breast cancer and no one is looking for stroke. What about the incidence of ischemic stroke? Is it different in women compared to men? When we talk about ischemic stroke and hemorrhagic stroke, it seems that they have a lower incidence than men. But when we look to the specific age group, we can find that in a younger age group, less than 55 years, women and men, they had a similar age-specific incidence. But in an age that is greater than 55 to 75 years, it seems that the men, they have a higher incidence. But after that, and mainly above the age of 85, it seems that women tend to have a bit of a higher incidence compared to men. When we look at hemorrhagic stroke, it seems that it's more common in men and lower incidence reported in women. But for the subarachnoid hemorrhage, it's more common in women, actually. This study was done by Prof. Adil, and it's done in Saudi Arabia in Asir region. And as you can see that the incidence of the patient who are hospitalized for their first time stroke was higher in male. But when we look at different age group, you can see that these small dots, they are representing the females. It was a bit strange that around the age of 45, the incidence was higher in women. But then after that, with increasing the age, especially above the age of 55, as I mentioned in the previous slide, it seems that the stroke incidence is higher in men. But don't forget that there are things that are specific to us as women, and it will make us at a higher risk to have a stroke compared to males. And especially when we talk about the oral contraception or contraception in generally, and pregnancy, the having eclampsia or pre-eclampsia. During the pregnancy, if the patient started to have diabetes or hypertension, also the postmenopausal period and the use of the hormones. The other thing that I feel that we are quite unlucky with that, there are risk factors that can be found in both men and women, but it has a greater effect and a higher risk for stroke if it happened in a woman, especially migraine with aura. AFib, also the regular risk factor like hypertension, diabetes, and the psychological stress. There are things that we don't know exactly the impact or the difference in the impact in men and women, like the obesity and the other things like diet and smoking. So here I will start talking about each category that is related to our hormones or that are related to us in a specific. And starting with the first thing that a woman might notice while she was in her younger age. And this is the endometriosis, which is the presence of the endometrial tissue, but outside their normal space, outside the uterus. It's usually known to us as a stroke neurologist that it's a chronic inflammatory disease where a woman is having a painful period, and it's associated with a hormonal disruption and immune system activation. It's mainly affecting women in their reproductive years, so when they are young, and actually it's quite prevalent. So it's found or diagnosed in 1 in 10 women. So it's a common disease. The interesting thing that actually was mentioned in the AHA-ASA guideline about the primary stroke prevention in 2024, they mentioned that endometriosis is actually associated with an increased risk like an increased risk to have hypertension and hypercholesterolemia, and subsequently it's associated with an increased risk of stroke. So when you have a stroke in young, a woman that is coming to your office with a stroke in young or to the hospital, you should ask her about the history of endometriosis. And if a woman is having an endometriosis, it's actually recommended to screen for the modifiable risk factor as hypertension or the elevated lipid profile. So when there is a woman having endometriosis, treat that. The other thing that actually I think all of us, all women, they use it at one stage of their life for one reason or another reason is the contraception and the hormones. It was found in USA that around 65% of women between the age of 15 to 49 are using contraception. And there are ways of contraception, including the natural ways, the barrier, the oral, and also the so many things, injections and others. And there is a very important relationship, and I'm sure that all of you know about, that there is a direct linear relationship between a high dose of estrogen and increased risk of stroke. So whenever you are using a higher dose of estrogen, there will be a higher risk of stroke associated with it. But is it really risky? So one of the common questions that we receive in the clinic, or maybe a gynecologist might receive it in her clinic, that what is my risk to have a stroke when I use the OCP? It's not that huge risk, actually. It's low. If you compared a woman that is using a low dose of a combined hormonal contraception to another one that she is not using any, her risk of getting a stroke is increased by 1.4 or 2 folds. So it's not that much. But again, you have to look to each woman in a different way, meaning when you are dealing with an older woman, or with a woman with a hypertension, or she's a smoker, or she's someone having a migraine and she's obese, is quite different when you are treating someone that she's young, in her 20s, without any medical risk factors, and she is thin or slim. So it's quite different. And it's mentioned here clearly that when they look at the patient's age, when someone is using the combined hormonal contraception, and here we are talking about low dose of a combined hormonal contraception, the risk actually to get a stroke, it's 3.4 to 64.4 event per 100,000 person per year. And this is increased based on the age. So the 3.4 is for a woman in her 15, or a girl in her 15, while it's 64.4 when a woman is reaching her 50s. So it's quite different when you prescribe it to someone that is young compared to another one. Not only that, when you are dealing with patients with migraine with aura, and that's very common in our clinic, the risk will increase by 6-fold. So it's not only a 1-fold increase, but actually a 6-fold increase when someone is having migraine with aura. So be cautious with that. Here you can see in this table, there are different ways of contraception, and if they contain hormones or not, and if they have an increased stroke risk or not. And that's very important to us as a stroke neurologist. We encounter that in our clinic a lot. I usually recommend for patients with a previous history of a stroke to use those that are non-hormonal in type, and those including the barrier and the other natural ways, or the surgical sterilization. Then when you look at the progestin only containing either injections or IUD, or even the implantation or the pills, you can see that the increased risk of stroke is actually none. And that's very important again for our patient. I did face a young patient that was having menorrhagia, and she was given the OCP and she developed cerebral venous thrombosis. So after that, we opted to give her progestin-only pills because she was still complaining of severe menorrhagia, and we had to start on the same time the DOAC. So it's important to know that. When we look at the combined hormonal contraception, either being a patch or a ring or an oral contraception, when you are below the 30 microgram, the risk of having a stroke is not that much. So it's still low, but it will get higher when you reach the 30 microgram. When you reach more than 50 microgram, it will increase significantly. What about those pills that we see in the market? I think Yasmin is one of the commonest one that is used, especially here in Saudi. And the level of the estradiol here is around 30 microgram, actually. So it's something that is not very low. It's not 20 and not high as 50. It's 30. What's mentioned in the guideline? So it's mentioned again in the American Heart, American Stroke Association guideline that you should absolutely ask your patient about the contraception that she is using. And in those patients that they have a specific stroke risk factor. And interestingly, when you look at what's written here, they wrote an age of more than 35. So they consider women that are older than 35 and they are using the contraception that they are combined, they are actually women with a stroke risk factor. So not 60, not 55 or 50, it's 35. And especially if she's a smoker or a hypertensive or having a migraine with aura, and she wants to be on contraception, you have to counsel this patient. And on the same time, it's better to prescribe those patients the progestin-only contraception or a non-hormonal contraception. So this is about the contraception part, and moving after that. So what if a woman stopped her contraception and got pregnant? So interestingly, that pregnancy is more risky than the contraception. So being pregnant or postpartum, and postpartum, we are talking about 6 to 8 weeks, they have approximately triple the risk of a stroke compared to a young adult of a similar age. Not only that, the problem that pregnancy-associated maternal stroke is rare, occurring in 30 per 100,000 delivery, but when they happen, they have mainly a catastrophic outcome with a high morbidity and mortality in such cases. Most of those cases actually occurs in the postpartum period. They can happen absolutely during pregnancy, but mainly in the postpartum. And the highest risk is actually in the first 2 weeks postpartum, but this extends to 6 to 8 weeks. As I mentioned, that it constitutes a leading cause of maternal morbidity and mortality when it happens. So why it happens? It can happen due to physiological changes that occurs in our body, but at the same time, it can result due to pathological changes. The physiological changes is the hypercoagulability and the cardiac remodeling, and at the same time, the hemodynamic changes that happens during pregnancy. They all can predispose a woman to a venous thromboembolism, but also an arterial one. Not only that, the pathophysiological changes that a woman, when she is pregnant, she can have either hypertension, and not only the hypertension, but it can be acute, like the preeclampsia, and it might be associated with endothelial dysfunction that will result in an either dissection or reversible cerebral vasoconstriction syndrome or the PRES. All these, they can happen during pregnancy or in the postpartum period. The risk factor for a maternal stroke, number one, is hypertension. We used to know that for any adult individual that hypertension is the most important modifiable risk factor, and it's the same during pregnancy. So it's the strongest modifiable risk factor that you can actually treat and prevent stroke. Getting pregnant while the woman is older, in her age, in her 40s, or above 35 actually. Having migraine again, obesity, smoking, heart disease like previous MI and other vasculitis, and an assisted reproductive technologies, they are associated with a higher risk of maternal stroke due to the hormones that are used at the beginning. So the thing about hypertension that I would like to mention here, that the thing about women, it seems that they have a higher incidence of stroke compared to men. Not only that, when women have hypertension, they are at a higher risk of first stroke compared to men. So it has a worse outcome in women compared to men. And that's mentioned in the guideline again. When you face a woman with a hypertension during pregnancy, this should be treated in case of a chronic hypertension and also acute, and your target blood pressure should be less than 140/90 to reduce the risk of stroke. The other thing, after pregnancy and after delivery, when you see a woman, and I think this is our practice, when you see a woman that she had a previous stroke and she comes to you after that for a visit, so she's not pregnant anymore now, but this is considered as a pre-pregnancy, you should counsel her and you should tell her about the contraception that she might use and if there is any plans for a future pregnancy. And that's a very common discussion in the clinic. And one of the important things that you need to tell her, as I told you before, that she could use the hormonal contraception, but progesterone only containing, and avoid the combined pills. So I avoid the combined pills regardless of their dose, actually, in such cases with a previous history of a stroke. What about if your patient is taking the antithrombotic and she get pregnant? If she's taking either antiplatelet or anticoagulant. So if your patient is taking either clopidogrel or the acetyl salicylic acid, or when it's combined with pyridamole or the TECA, once pregnancy is confirmed, you have to switch this patient to a low dose aspirin, the 81 or the 100 milligram daily. If your patient is taking warfarin, so warfarin is teratogenic and this should be stopped and switched to low molecular weight heparin. DOAC, safety in pregnancy and lactation, it's considered as category C and there are limited data about its safety. So again, it's not used and switched to low molecular weight heparin. So we finished now with the pregnancy and the postpartum counseling. What about when we get older? Is it better or not? It seems not that much actually. So what happens at the menopause or the perimenopausal time, as you can see when we are young and during the reproductive age, the estrogen at the highest level and it reaches the peak. But after that, in the perimenopausal period, it starts to go down and the levels will be low and the decline will continue until the menopause. So menopause is a loss of the ovarian follicular activity and there is subsequent decline in the estrogen production. And this is usually happens between the age of 45 to 65 in 90% of the women. But sometimes there are other women that they face what's called a premature ovarian failure. And this means that they will have their menopause before the age of 40. Not only that, it might happen between the age of 40 and 44, and this is called the early menopause. The bad thing about that it's actually associated with increased risk of a stroke in those women. And why this will happen? Because when estrogen goes down, the LDL level will be elevated. Not only that, the HDL will decline and the blood pressure starts to elevate. And that's why the risk of a stroke will increase with time. Not only that, it was found that having the hot flushes, and it's experienced by more than half of the women having their menopause or in their perimenopausal time, it was found that severe and frequent symptoms of hot flushes are associated with increased risk of cerebrovascular disease. So that's a bit weird. And why it will happen, we are uncertain about that, but it might be linked to the estrogen-based therapies. How can this happen? Because estrogen-based therapies are actually the most effective treatment for the moderate to severe vasomotor symptom. And it's well known that the hormonal therapy or the hormonal replacement therapy associated with increased risk of cerebrovascular disease, particularly the oral form. So what does it mean? Or what shall we do? So hormonal replacement therapy, it was found in 2022 that the use of estrogen-only formulations resulted in 97% or 97 more strokes, in 10,000 women treated with that. And if they are using a combination of estrogen and progestin formulation, it resulted in a 52 more stroke per 10,000 women. So again, with both type, it's increased, the risk is increased, but it's higher in estrogen only. طيب, shall we keep them without anything and suffer like this lady, like thinking that she's doing well during her menopause? No, actually not. We can help them, absolutely. And I think this diagram, it's a very nice one. It's in the American Stroke Association, that actually talking about how can you deal with those women in a way that will not increase the risk of a stroke. So in those women that are having a hot flushes, you have to treat them if it's moderate to severe. Number one, consider the patient age. If the patient is younger than 60, that's much better. So try to avoid it if they are more than 60 years. And during the first 10 years of the menopause, and check if they have a history of a breast cancer or they have a thromboembolic event, either an arterial or venous or MI or liver disease. And if they have like none of these, then you can actually start them on a hormonal therapy and try to avoid the oral formulation. The best way is to go for a transdermal and the lowest effective dose of estrogen in such cases. What about the recommendation? I think I'm reaching the end of the presentation. What's mentioned in the American Stroke Association guideline, that when you are seeing a patient with a stroke and in her 40s, you have to ask her, and even before the 40s, you have to ask her about her period, if she is having a premature ovarian failure or an early menopause or not, because this is associated with increased risk of a stroke. Not only that, when you are facing a woman like this, like especially maybe in the PHC or with a gynecology, they have to look for the risk factors. They have to measure their cholesterol level and others, and LDL and HDL, and the blood pressure, as it's associated with increased risk of dyslipidemia and hypertension. And in a woman that is more than 60 years of old, with more than 10 years of a natural menopause and an elevated cardiovascular disease risk factors or previous stroke, avoid the hormonal replacement therapy. And the European Stroke Association actually voted against the use of hormonal therapy for all the cases, for ischemic stroke, for hemorrhagic stroke, and also to reduce the mortality. So it seems that our hormones, they play a very big part of our life and our physiological changes and pathophysiological changes, but do not forget that a woman is the full circle, and within her is the power to create, nurture, and transform. By this, I reach the end of my presentation, and I hope that it was fruitful and also full of information for you. Thank you.
Thank you so much, Dr. Nouran. It was a very excellent presentation, and I would like to congratulate you on your new nephew. يتربى
Thank
في
you so much.
عزكم وربي يجعله من الذرية الصالحة يا رب. Now, I would like to move on to our next presentation by Dr. Aisha Ibrahim Al-Bakr, who will present 6 specific disparities in stroke care from presentation to long-term recovery. Dr. Aisha Al-Bakr is an associate professor of neurology at College of Medicine in Imam Abdurrahman bin Faisal University. She is a consultant neurologist and a strokeologist in King Fahd University Hospital, Al Khobar. She is the program director of Neurology Fellowship in Imam Abdurrahman bin Faisal University, Dammam. She obtained her MBBS with honor from IAU in 2010, finished her neurology residency at Imam Abdurrahman bin Faisal University in 2014, and did her clinical and research fellowship in stroke at Ottawa University, Canada in 2017. She has been the head of stroke unit in King Fahd University Hospital from 2017 till 2023. Welcome, Dr. Aisha.
Thank you very much for a nice introduction. It's my pleasure to, I don't know, can you see the slides? So it's my pleasure to join MENASO webinar to discuss this important and rapid evolving topic. Thanks also Dr. Nuran for nice and informative, well-structured, mashallah, presentation, and مبروك على الولد ولد اختك الله يحفظه يا رب العالمين. Today, I look forward to share insights and learning outcome during toward the six difference in term of stroke care from acute management to long-term recovery. So so we all know from stroke is a leading cause of death and disability worldwide. Equity of stroke care is a core quality indicator. Previous data on 6 difference were limited, and we know that we have current evidence reveal there is still large gender gap. I will start my presentation with 2 real cases we saw in our hospital. The first case is a young woman arrived at the emergency department after a family conflict. She complained of right-sided weakness and headache, but also she was crying and emotionally distressed. An initial non-contrast CT was done and was unremarkable. She discharged home with emotional support. Overnight, unfortunately, her weakness gets worsened. She returned to the next day unable to move her right arm or speak clearly with NIHSS of 16. Repeated imaging unfortunately showed a malignant ischemic stroke with arterial dissection that was not recognized on the first visit. So what went wrong? So here the patient experienced a missed stroke due to diagnostic overshadowing. And we think that this might be a system-level triage failure because the stroke protocol may not be activated due to atypical presentation as well as bias-driven triage decision. So unfortunately, this delayed recognition until catastrophic progression occur. On the other spectrum, another case scenario of 72-year-old woman, she's a widow with hypertension, hyperthyroidism, living alone with a personal caregiver, which was her maid, was preparing for wudu before prayer. While she is standing in one leg to wash her foot, she fell down. She was found on the floor, screaming in pain. EMS was called immediately, and the case was reported as an elderly fall with suspected hip and arm fracture. And this is what happened. So when she arrived to the emergency, they showed complicated hip fracture as well as arm fracture. So she underwent hip fixation surgery and arm immobilization cast. So the primary focus remained orthopedics. Post-operative day 2, the daughter noticed that her mother is like confused, abnormal speech. She had some paraphasic error, and more concerning that she is not seeing anything on her visitors on her right side. So neurology consulted in day 3. And by that time, examination revealed that she had right homonymous myopia, conductive aphasia, upper motor neuron facial weakness, upgoing plantar. Yes, neurological motor exam was limited because of the cast and surgical fixation, but it was limited as compared to the other side. her CT showed already established infarct, and actually her ECG was atrial fibrillation from the beginning, and she was prescribed some anticoagulant, but she was not taking it at all. So what happened here? So as compared to the first case here, what happened is what we call is anchoring bias. This means that fall and fracture is masked the symptom of a stroke. And the reason why she fell down is not actually from the beginning because of the stroke. So it was weak on that side. That's why she was fallen on that side. So a neurological exam limited by pain, cast, and surgery, stroke was recognized late after infarction established. Looking to the two cases, case A and case B. Case A, a young woman, emotional distress, normal early CT, labeled functional, discharge, returned with malignant stroke. Case B, elderly, widow, fall with a previous fracture, with obvious fracture, stroke sign, masked by trauma, delayed in neurological consult, established infarct with AF. In both cases, we can say this across different ages and clinical context, both cases demonstrate delayed stroke recognition, and driven by the diagnostic complexity and system level factors, not only biological alone. So when we look to the critical gap across the stroke pathway, we have to analyze it step by step. Is the problem in the recognition? Is it the problem in the acute treatment timeline? Is it in the decision itself? Is it in the secondary prevention? Or is it in the rehabilitation? To understand that, there's a nice paper which is published recently by the World Stroke Organization regarding the address sex and gender differences. And we all know that it is not something easy. We know it is multifactorial. We have biological factor, we have social factor, and all of these biological, they are interactive together. And by the end, it will contribute to the acute reperfusion therapy, EVT or IVT. But whether this is due to access barrier, whether these social or biological factor contributed to the access barrier, to the decision challenge, is a diagnostic challenge, nobody knows. But by the end, we know that there's no difference or no evidence in treatment effect modification by sex. And by the end, in long term, compared to men, women suffer from increased disability. This is the main question of that review. We want to investigate whether these factors, biological or social factor, can influence the decision or treatment decision for stroke. So how stroke factor contributed to the stroke care pathway? We know that we have independent variables that was presented nicely by Dr. Nouran. We have these biological and psychological factor, but our role as a physician, as a neurologist, as a future neurologist, inshallah, so is to work on these dependent variables. Like there is evidence show that there is a delayed in stroke recognition, lower pre-notification, delayed brain imaging, delayed in diagnosis, reduced access to time-critical reperfusion, and lower access to rehabilitation. These dependent variables we need to focus on. So start with these multi-level. So first of all, let's see the evidence regarding the pre-treatment recognition. On a large review showed that women are 16% less likely to be diagnosed at a pre-hospital. 1 in every 4, 25% have higher emergency department misdiagnosis rate with non-focal symptoms, reduce the PFAS sensitivity, which is commonly used. MRI is not routinely used because, and that result on underdiagnosis of minor stroke in women. These differences persisted even after adjusted for age, severity, and comorbidities. Another national stroke registry, and we figure out this difference, and they become more clear for us when we see the national stroke registry, real world life. So this is a very nice registry about including 845,000 stroke patients across like many countries over 10 period, comparing the stroke care system. And here they found that yes, the women receive similar acute treatment comparing men and women. But what is the difference? The difference is come to be that women less likely to trigger stroke pathway. This means the emergency to arrive by ambulance. And this is something critical, and because it is really clinically significant. And also women less likely to arrive within the treatment window. Later representation more common in women, and they also higher severity. Looking to them, each NIHSS, they found that women, comparing men to women consistently have lower EMS pre-notification across all, as you can see in this nice figure, across all NIHS category. And what is the implication of that? This means that delayed pathway activation despite equal or greater severity. This is like, we need really to realize that the problem is not like related only to biological. So lower EMS pre-notification in women may delay stroke pathway imaging and perfusion despite having similar or greater stroke severity. So now we finish from the first step, and we recognize that this has the highest impact. Now come to the, once the patient arrived to the emergency, will the evidence show there is any difference in the acute treatment timeline in the decision or no? The evidence showed in a nice review by World Stroke Organization, overall, across many studies, it showed that the woman 13% less likely to receive the correct IV thrombolysis. So overall, the 13%. Although this has been improved from past as compared to now, as you can see, like 2000 to 2004, yes, it has improved, but it is still exists, especially in some area like Europe and US. And most importantly, looking carefully to the delay, they found that most of the barriers occur before eligibility determination. So maybe this means the decision, not after that. Where is the gap occur? Like, is it the problem is in the door to needle time? So we need these KPI. As a strokeologist, we look at to the quality of the stroke care by looking to some parameters, some KPI. So what about the door to needle time? Many registry, like Australian registry, Vista registry, North Test, all of them, they found there is no actually 6 difference in terms of door to needle time, although women slightly less likely to meet less than 60 minutes. However, in the National Stroke Registry, they found that female sex was independently associated with delayed or lower likelihood of receiving time-sensitive stroke. And the largest, as you can see in this figure, that it's related to the door-to-needle time, is less than 1 hour, entirely effective, like receiving the accurate within 4.5 hour window, and also in the diagnosis early neuroimaging. So these things, like they, I mean, this one, they did it after they did multivariable analysis, and they did the, and this was adjusted. So it is real factors contributing. What does that mean? This means that these are statistically significant across most acute and early inpatient care metric, indicating a systematic pattern. It is not, we cannot blame only the biological factor. So it is not isolated by variation. Okay, what about the safety? Is there any difference if you give the patient IV thrombolysis? Is there different? Actually, the evidence is mixed. However, mostly they said, Europeans said it is similar, while SITs showed like higher even in men. However, safety, we cannot say that there is a difference between men and women, like almost it is similar. But about now, we know that for acute treatment, we have IV thrombolysis, TPA-TNK, and we have, of course, the endovascular thrombectomy. And there's across 51 study, a review showed that there is no sex difference actually in terms of the endovascular thrombectomy. Although European, they said it is slightly in women, and this is why, because women, as you know, they are more prone to have atrial fibrillation, more prone to have severe stroke and higher NIHSS, and of course, large vessel occlusion. And that's why higher AV thrombolysis. Functional outcomes similar in women and men by the end, and the perfusion success was not sex dependent. Okay, so what about the ICH? Is there a difference when you talk about intracerebral hemorrhage? Is there any acute care gap? Women less, because from the beginning, so we again back to the pre-notification, women are less likely to be activated as a stroke code, and so they are less likely also to receive full ICH care on them. Do these difference, and this is what we need, do these difference matter clinically? The answer based on the National Stroke Registry showed it is no significant difference in terms of survival, but women have worse functional outcome even after adjustment. And functional disability remains significantly higher in women, independent of their baseline difference. We know that. Why this difference in stroke care and stroke care in women? Why now it has become more obvious? Because we have to all recognize that in most of the trials, they exclude the women, and so women are underrepresented in many trials, and this is mainly because that the age and the pre-stroke disability, which is the MRS, has been exclude women, and we know most of women are fallen in those group, older and having they are having more prone to have osteoarthritis, and maybe that's why they can be represented in real world female data. So when we're comparing to the trials as compared to the registry, now we can see there is a difference. So again, so just go back to this pathway. So recognize that highest impact in the pre-treatment recognition. Yes, there are mixed evidence regarding the acute treatment timeline and eligibility decision. Okay. Now, what about secondary prevention? Is there any gap? Actually, yes, there is. Unfortunately, women are still missed in the secondary stroke prevention, are less likely to have medication initiated, both spectrum of age. Those who are young and also those are old are more likely to discontinue therapy. And this is age specific, not only biology driven. Maybe one of the explanation that young women may be likely to a contributor are concerned about pregnancy, drug safety. So mostly they stop their medication. And this can be a missed prevention window. We know atrial fibrillation, yes, higher in women as compared to men, 23 versus 17. Despite high risk, women less likely to receive anticoagulation at discharge. Or for me, I found it is very common that they take not correct dose. So instead of taking apixaban 5 BID, they take it 5 OD or something like this. So that's why they are higher risk to have a recurrent stroke risk. What about the intervention? So we are talking now under the umbrella of secondary prevention. Women, in terms of carotid artery stenting, women have 30% higher preoperative risk of stroke and MI, unfortunately, and risk difference diminished over long-term follow-up. While in terms of carotid endarterectomy, in a recent paper, 2023, they found that women have nearly double the restenosis rate as compared to men, which is with odd ratio of 2.81. One of the proposed contributory factor is the anatomical factors in women. Women are more like to have more prone to have smaller, this is their anatomical, smaller arterial diameter and greater vessel tortuosity. And many trials, including 28 to 34, so only like 1/4 of the whole, they represent women. So we can see that there is insufficient power to really compare carotid endarterectomy versus stenting in women, and maybe this is a future direction. Okay, so like one of the papers, they said that maybe for women, one of the things that we need to tailor your procedure approach using narrow stent or technique optimization. However, need more trials to see that. My last station regarding the rehabilitation, any gap in the rehabilitation, women less likely to receive access early rehabilitation in Australian registry. However, that showed that although there is a kind of difference in reaching that early rehabilitation, but the outcome is almost similar between men and women. And also in this national registry showed that actually there is no much difference when you do the multivariable regression analysis. It is not a largely contributory factor as compared to the triaging patient. Okay, so what about discharge destination? Women likely to be discharged to the rehab center, men more likely to be discharged. And of course, they are diversity, including older age, greater stroke severity, and reduced availability of family caregiver in women. Long term, we don't know why, but usually women have longer term, they have worse outcome as compared to men, and adjusted attenuated, but did not eliminate a sex difference when you adjusted. So now we analyze this gap. We can understand that majority of the gap, like the highest impact, I keep saying I found it's pre-treatment recognition and notification. And as I say, that barrier mostly occur before eligibility determination. These gaps highlight that it is system-level failure across stroke pathway. So now, from describing the problem, how to go to treating the problem, what we can do, what are the solution, future direction to reduce both research and the treatment gap. So these are the nice figures. So like we can provide gender responsive therapy, consider female specific risk factor. Anyway, I'm going to discuss this in my coming slide. So, as I mentioned, that my main focus is pre-treatment. So what we can do to improve this pre-treatment and recognition notification? We know that EMS and emergency department training is very important to emphasize symptom variability by sex and avoid non-classical dismissal. And our goal is to reduce pre-hospital delay and loss of eligibility pre-perfusion. So this is very nice paper regarding the strategies to advance stroke care in women. And they found that the key, if you want really the quality improvement, is to standardize EMS activation, stroke code triggers, imaging timeline, and reperfusion eligibility, with aim to have that equality between and post-stroke care. Of course, awareness, we all know that such events, as Dr. Noram mentioned earlier, that's like Go Red for Women, kind of increase awareness of women-specific risk factors. One thing that's very nice, and we know that this was published by the American Heart Association, like we know that they provide this algorithm for women just to recognize those who are at a high risk. So if the patient has, for example, a high abortion, like a history of a preeclampsia at any way, so if it is positive APO secrete, this should trigger lifelong vascular prevention, shouldn't be reassured. What does that mean? This means like if you have patient who has like non-specific symptom, plus she has positive APO, this should trigger this pathway. This means you have to raise your suspicion and prevent missed stroke. So this is one of the proposal just to increase awareness of them and not missing women. I found also one of the good solution is to report KPI side by side by sex, not just overall average. This means we need to make sure that we have equity gap become so more visible, and and we need to monitor by using stroke registry and quality dashboard. And not only that, we are only collecting the data, we need to provide targeted feedback. This is just kind of, these are not real numbers, just I am kind of just to show you how such a KPI. Usually what we did in our registry, for example, we do, for example, median door to needle time or whatever, just to do overall median to door to needle time. And instead of that, why not do it like men versus women? And by that, we can, the difference become more clear. And so the action will be clear. So we know what we're gonna target. So by embedding 6 stratified KPI, transfer equity from an abstract goal into measurable, correctable quality of care standard. We need sometimes, yes, there are something that I feel like it is kind of a misconception, that we reassess rigid exclusion based on age, pre-stroke disability, promote more individualized. The decision should be individualized and reduce what we call risk-averse bias, which I'm gonna describe it in my next slide. Just to make brainstorming, like this is another case, 89-year-old a widow, live alone. She had baseline function bilateral knee osteoarthritis. She is using cane, limited outdoor mobility. However, she has good cognitive function, excellent communication. She is managed conversation. She is also can help herself. She is totally dependent. And however, she was recorded because she is using cane as a pre-stroke MRS of a 3. Okay, so how she developed sudden onset aphasia, right-sided weakness. Time lasting normal was 75 minutes, and IHSS when she was attended was 7. CT showed no brain and a good aspect, no hemorrhage, and aspect was 9, and there was no absolute contraindication to IBT. But there, the decision was hesitating because given that she is not mobilizing, what's maybe because of the MRS. Anyone suggest that no, we shouldn't give this patient TPA because, for example, her MRS is 3, so is more than 2, maybe we'll not give. Actually, so there is 2 options, either no thrombolysis or we can still offer thrombolysis. By the way, this is even including thrombectomy. So, and this is what you call risk-averse thinking. What does that mean? Treatment is withheld because of fear, not because of a true contraindication. We don't want that the problem occur. What is the problem with risk aversion? Why it is harmful? Because it can lead to under-treatment, convert potential recovery into permanent disability, and create systematic inequity. It's often invisible unless it is audited. And regarding the pre-stroke MRS, having knee osteoarthritis, and this is I found it many think that knee osteoarthritis or chronic immobility or higher pre-stroke MRS due to non-neurological cause, especially osteoarthritis, does not itself exclude the patient from receiving acute stroke care. And we should look at the patient as a whole, functional meaning of life pre-stroke, cognitively intact, independent communication. Mobility limitation is not always equal to poor quality of life. And patient value is also important. Communication and cognition are central to independence. What happened to that patient? She meets standard IV thrombolysis eligibility. Image profile is favorable. So we think that she can deserve an IVT should be offered for her. And that was also the message from the World Stroke Organization principle. You need to treat the patient as a whole, and disability should be interrupted in context, not as a binary exclusion. And this is a very good message. If we give it to our trainee, to give it to our emergency, that not to exclude because of, so sometimes MRS or disability can be misunderstood. Lastly, inshallah, I come to my next slide, to my last slide regarding we need also strengthening the secondary prevention pathway. We need targeted action work. So we need to move from prescription to persistence. Maybe one thing that we need to standardize post-discharge follow-up. For example, we need to have in the refill clinic always to ask the patient about the common side effect, about concern if she is planning to pregnancy, to reassure, and so on. So all of these and of course, if someone is discontinuing medication, it's also to audit it just to know for measurable quality action. And lastly, regarding the research and title, we know that we know that there is a gap in research, gap in the guidelines, and mostly because the trials, as I mentioned. So redesign the eligibility criteria, study decision-making bias, so investigate where and why women are excluded across the stroke pathway. So it's in the pre-trial, trial phase, as well as in post-trial phase. So in conclusion, 6 differences are driven by access, timing, and system factors. Treatment efficacy is equivalent when therapy are delivered. Greater gap occur before eligibility and recognition and in the decision itself. Addressing this gap is a major opportunity to reduce population-level disability in women. Many thanks for your listening, and I'm happy to hear any questions and open for discussion.
Thank you so much, Dr. Aisha. Thank you, Dr. Nuran. Excellent talk, very informative. And I would like to highlight just a few things from Dr. Nuran, the importance of a modifiable risk factor and the early management, like treating hypertension aggressively when we are dealing with stroke in women, and highlighting the contraception, the risk of contraception is added will have a cumulative risk when we do have many combined risk factors. And as Dr. Nuran said, the antithrombotic, the aspirin, is safe during pregnancy. Low molecular weighted are safe during pregnancy. And in regard to Dr. Aisha, excellent talk, Dr. Aisha. Thank you so much. I would like only to highlight that it's sad to know that all this disparity of care at all level, biological, anatomical, social. So you're completely right. We have to report the measures and the KPI. We cannot manage what we cannot measure. So I'll start with the first question by the audience. Question one to Dr. Nuran. Hypertension is a risk factor for hemorrhagic or ischemic stroke. Which one is strongest risk factor, Dr. Nuran?
Yeah, I would say that it's a risk factor for both. So for ischemic and for hemorrhagic stroke. And as it's mentioned in the guideline, actually, they didn't specify that it's carrying a higher risk for a hemorrhage in specific or ischemia. Although few things mentioned that a high blood pressure might be associated with a higher risk of rupture if the patient is having a previous vascular malformation. But to keep it simple, I would say for both.
Okay, question number two for Dr. Nuran. I think it was from Pakistan. So they are questioning why in Pakistan they do have cerebral venous thrombosis. They see more CVT than arterial stroke postpartum. Do you have any comment on this?
I think Dr. Hilana and all the others, Dr. Aisha and Dr. Salama, we all agree that we do see venous thromboembolic events more than arterial in a postpartum period. And I believe that is related to so many factors. So including the hypercoagulability that the woman is having while she's pregnant and in the postpartum. Not only that, but after delivery, they are usually a sort of dehydrated. There is an increased risk of infection that is related to the delivery. All these put the woman at risk to get CVT or a PE or a DVT. So I wouldn't say this is only in Pakistan, but I believe that's worldwide.
Okay, thank you, Dr. Nuran. Dr. Salama, do you have any questions?
Well,
Okay,
excellent talk.
yeah.
Oh, sorry.
No, it's
Excellent
okay,
talk,
Dr. Salama.
Dr. Aisha. I totally agree with the 6 disparities that they do occur, and I think that not necessarily they're just within the EMS, could possibly be within the neurologist ourselves as well, because especially when it comes to like young female coming with acute neurological deficit, stroke might not necessarily be the first differential, especially with the rise of demyelinating disorders nowadays, such as MS. So I think misdiagnosis can occur, and it's crucial for us to discuss and bring out more on women and stroke, such these webinars, these sessions. I think they're great. And if we look at Dr. Nuran presentation and reflect on that, we'll notice even the AHA guidelines have listed women age of 35 and above, which is lower than the regular age when it comes to men, with a higher risk of a stroke or cerebrovascular events, especially with additional comorbidities that coexist with them. So highlighting this, I think, is very crucial for all of us.
Yeah, I do echo Dr. Salama. Definitely, we do have a misdiagnosis, unfortunately. A part of it is because the nature of the problem, like in dissection, in CBT, in press, the symptoms can be non-focal. A patient can present with headaches, so we need to have a low threshold for recognition. My other question is for all. We will get always consultation from the obstetrician regarding the preferred mode of delivery when we are talking about maternal stroke and the preferred anesthesia. So I would like to hear from you, expert, regarding this matter.
Dr. Aisha, if you can start, please.
Yeah, so I think this is also one of the thing. For me, I found that it depends on the risk of the patient. So if she is at a high risk, we know that's usually here we need to balance the weight and risk of the mother and also of the fetus. So I think in some situation it might be that we cannot say for cesarean, but I found that cesarean section in this case, especially if the patient is at a high risk, those patients, like I have patient like she is, for example, having high thrombosis, SLE or whatever, and we know that she was in for whole pregnancy on anticoagulation. So at the time of the delivery, will you wait and give her like going for the delivery? Yes, this is her. We don't want to prevent her from. This is the normal delivery, and we know that this is our the natural thing and normal thing. But in such cases, because we know that during the delivery, we don't want the risk also for the baby at the same time. So in such situation, we don't want the patient to be in the long like prolonged labor, or that. This is, I think, one thing that always we need to consider. So I don't like Dr. Nuran, if you have any other thing.
Yeah, thank you, Dr. Aisha. I think that's a very tough question, Dr. Hilana, to face usually. And it's mentioned in the Canadian best practice for stroke. And as far as I remember that it was clearly mentioned that we cannot recommend cesarean section for all women with a previous stroke or a patient with a stroke. Actually, it's based, as mentioned by Dr. Aisha, in each case alone. And it seems that she can go also for a normal vaginal delivery. So it can be either one of them according to the situation itself.
Yeah, sure. Thank you. Thank you, Dr. Nuran. Vaginal delivery, as you know, is sometimes preferred when we are talking about maternal stroke to avoid the surgical risk and hemodynamic stress during a C-section. So when we do have obstetrical indication, definitely we'll go for C-section when this is, in my opinion, and when we have the maternal safety, of course. It depends upon each case by case. And regarding the anesthesia, do you have any recommendation whether we go for neuroaxial anesthesia versus general anesthesia in case we need any procedure?
I would say again, it's not mentioned specifically in guideline which anesthesia to go for, but it's completely different when you have someone with a cardioembolic stroke than another one having a stroke related to a dissection or a carotid disease. It would be again case by case. I think it's really difficult to generalize or to recommend one type of anesthesia over the other.
Yeah, unfortunately, these questions will remain unanswered until we'll have inclusive trials. We are counting on you, Dr. Salama. You are our future strokeologist. You have to make inclusive trial, including all these unanswered questions till now. I would like just to mention that 3 days ago, the American Heart Association, as Dr. Aisha mentioned in one of her slides, published the updated guideline just 3 days, I think, 4 days ago. And in this guideline regarding the inclusion-exclusion criteria for IV thrombolysis, there was the expansion of the yellow guideline على حساب on the expenses of the red exclusion guideline. However, regarding pregnancy, we are still in the question mark yellow part guideline. So probably the benefit will be more than the harm, and it depends on each case and disability, potential disability for each patient. So we have to probably have more inclusive trials in this regard to have more answer to this difficult question. Anything, Dr. Salama, from your part? I cannot see in the audience any other question.
We have one question by Dr. Maria Khan. She
Okay.
basically thanks both Dr. Noura
Wow.
and Dr. Aisha for their comprehensive talk. So she's interested in knowing what your experience is concerning sex disparities in access to stroke care, and if women are being treated differently once diagnosed due to cultural reasons. And yeah, so she would like to know your experience in that.
So I think that's maybe in I would like to say in Saudi Arabia, or maybe also most of the Middle East. I feel like the women, especially that's at by age 70, 80, you find them like they are sitting, they're almost they kind of having osteoarthritis and they don't like mobilize. I don't know, for some reason. While I feel like this is one of the contributory factor we shouldn't we all recognize that, and this is maybe can related to many living alone. She is most of the symptoms are like not a clear symptom. Usually they come with the gray zone, not typical. And in one study, like nice that they don't have be fast, like even be fast, they are less likely to have be fast. So the trigger the EMS or trigger the emergency physician maybe is also missing, and we cannot say صبورين, like maybe there is also some element that they assuming that they are either emotional or maybe they are over representing symptom. So I feel like maybe this gap, that if we really highlight it and like personally, I found it's more clear with women because of this, like different representation, like atypical, sorry, not different, like atypical representation, living alone. Many times they are not witnessed. These are the things that make, I feel like the stroke care is different. Like this, if we want to highlight these things, more awareness, recognition of real difference and how they can present. I like the pathway that they mentioned, like having some risk factors maybe alarm you that you shouldn't underestimate stroke symptoms in women. So this is my like my observation from a real patient, but from our patient population. However, of course, we cannot say assuming that like we need to have real data. We have real registry metrics that we can observe, we can measure, and then we act, and then we hear the feedback. I feel like this is the way you have to look for the stroke pathway.
So there's an additional important question, and they're asking, do you think the extended window of stroke treatment in the new guidelines would change things? Because if in a situation where there is a misdiagnosis initially in alerting code strokes.
Still, like we know that extended window, you mean like to determine the eligibility. We know the sooner you give the TPA, the sooner the better outcome. So if the problem is in the recognition, whether it is, of course, we know that if they recognize earlier, they will, regardless of the extended window, like what we need to fix that we need to treat them not to give them not to put most of our patients within that extended window. Yes, we know that this is something that we can do, but we shouldn't say that
Depend on it.
yeah, we depend on that. Yeah,
Yeah.
we know that the
Early
sooner the better.
recognition.
By
Yeah.
the end, the
Early
sooner is better.
recognition when it comes to stroke is the
Yeah.
best thing.
Yeah, the sooner the better, of course, for the and less damage to the neuron. So of course, the sooner is better.
Sure. One more thing regarding neuroimaging in pregnancy. We used to know, they used to teach us that CT is contraindicated, CTA is contraindicated, and MRI without contrast, we can do it. However, all recent data showed that when we are dealing with acute maternal stroke, we can go for CT angio, because the radiation is very tolerable and much less than the radiation that we are feared from. Even the contrast can be given. However, the contrast of gadolinium, of MRI, cannot be given. So we can do MRI without gadolinium. The MRA time of flight, however, it's not very accurate like with gadolinium. And for the CTA, according to latest guideline, we can do it in maternal stroke.
Yeah, I would like to add, just maybe to add some like coverage for the fetus. Just I mean, like, for what is it? Forget the name.
The shield. The shield.
Yeah, the shield. Yeah. So just this thing that's super, as you mentioned exactly, that the radiation especially for the plain CT is like almost like it's minimal that. We all misunderstand that. We thought that it is contraindicated and we shouldn't give radiation, but actually, especially after the first trimester, it is reasonable. Yes.
Perfect. Any other question? Any other comment from Dr. Aisha, Dr. Nuran, Dr. Salama?
Maybe I have one for Dr. Nuran. So, Dr.
Okay.
Nuran, do you think is it essential or we should play more role in this by discussing with gynecologists, for instance, to highlight the stroke incidence in those pregnant women, especially with like comorbidities or patient with at risk of stroke, for instance, preeclampsia, gestational hypertension, that they should emphasize on doing stroke education for these patients, teaching them the be fast, teaching them the early sign. You need to come to the hospital. You need to, if these things happen, then you need to rush in to the hospital. Do you think this is a very crucial role that we should be more involved in?
Yeah, absolutely. I like the idea, and I think, yes, why not? I believe that everyone should be educated about the stroke symptoms, starting from the school age. And also after that, for women, definitely. We had a stroke code from actually the women hospital. We are a very big hospital where the women hospital is separate from the main hospital. And they had a patient with right-sided weakness post-cesarean section. And actually, the nurses there, they just didn't know what to do. Although they were educated about how to activate the code, they did activate the code. But then after that, they were just like stuck. We don't know. We've never faced such thing that in the floor. So it's really important to educate the nurses and to teach them how to activate the code, how to deal with acute stroke cases. And it's really catastrophic when you have a stroke case in a pregnant woman or when women with a preeclampsia or eclampsia. And maybe because in National Guard we are a tertiary hospital, we face so many cases with stroke while they are in the postpartum period and also before the delivery. And we had just a very recent young female with multiple bilateral MCA stroke that happened while she was delivering, actually, just before the delivery by few hours. So things can happen, and yes, we really have to be prepared for that. Totally agree. I think, Dr. Salama, I saw like two questions about the estrogen and about the hormones. So one was asking that if estrogen is a protective for a woman, and when we are in the menopause, the estrogen will go down, how the hormonal therapy containing estrogen will be a risk to have a stroke. And I think my answer is because this is an exogenous estrogen. We are not talking about an endogenous and something normal in our body. And I believe there was another one talking about the IUD, if it was a hormonal one, is it safe? So if it's a progestin containing IUD, yes, it's safe and it can be used to decrease the risk of a stroke in those cases. Yeah.
Yeah, Doctor, just
Oh,
sorry, Dr. Helana, just one point on the IUD, or the progesterone pill. I remember you gave a case where the patient has CVT, and then she was planned to be put on progesterone pills. But she was on DOAC. So my question was the DOAC decision extended because she was on the hormonal therapy, or it was just part of her regular therapy, which is for the CVT? Did it influence the duration or not?
So actually, this case, it was a difficult. She was a very young girl, around, I believe she was 19 something or 18 years, and she was having menorrhagia to the degree that she was anemic. Her hemoglobin was only 9, and they gave her the combined pills to control the menorrhagia. But when she received the combined OCP, she had CVT, and it was an extensive CVT. Not only even the deep venous system was involved. So it was an extensive one. We started her at the beginning on the enoxaparin, and then she started to have again a heavy mens. She was admitted to the hospital for a long time. So her period was very heavy, and we didn't know what to do. And I had, I believe, a very long discussion with the gynecologist that what shall we do? I cannot put her again on the OCP. She will have an extension of her stroke, and we need to shift her to DUAC later. But the decision was to put her on the progesterone only containing pills to control the bleed, and at the same time to keep the risk of CVT extension the lowest. And we continued after that from apixaban to DUAC, and luckily she was stable, alhamdulillah, and she recovered completely after that. I believe we continued on the DUAC for 6 months, and then we stopped it.
perfect. At least we ended the seminar with a good success story, Dr. Nuran.
Yeah, alhamdulillah.
Yeah, thank you all. We come to the end of this webinar, and I would like to thank the audience. I would like to thank the speaker, Dr. Salama. All your commitment is amazing, driving the mission of advancing stroke care across the region. I think you found it very valuable, and hope to see you in the coming webinar. Thank you again for everyone.
Thank you very much. Thank you for your
Have
attention.
a good night.
Thank you all.
Thank
Have a
you.
good night.
Same to you.
Night.